thing. So one thing is, you should see who is here. So Sandy, okay. Okay, good. All right. A large part of what I want to discuss today, I hope, and you'll be around. How long can you be around, Glenn? Theta.
Hey, Paul. Sorry, just getting on now. I'm good for all the time.
Okay, good. Because I want to have you talk a little bit about what you've done about ambulance parking there. You know, when you send your supervisors in and all that. And I want to learn a lot of different models that are out there. And
Sure.
over the next couple of days, we're needing them. I got a special request. In fact, I may ask you to see if you're available to speak around 9:15, 9:30 or so on Thursday on another your time on another Zoom meeting. Okay.
All right, let me check. Thursday, 9:15. Okay, let me.
Yeah, during that area. I'll give you more details about a specific hit time. Okay.
Okay.
I'm just going to gather different models about what people are doing about. And you've spoken about that directly in the past. All right. Sounds like we're starting to get a little bit of a quorum now, so that's cool. All right, so let's do this. So first of all, welcome back, my friends, to the show that never ends, right? And so today's CME password is 12996, 12996. At least that's what I was told. We'll double check and hope that's correct, 129. And those, if Florida's joined us, the Florida thing was 12997 that you just went to. All right. All right. And so one of the major themes I really want to address today is to talk about the whole thing about what people call wall time, parking, or whatever we want to say. And that whole issue of overcrowding, et cetera, is the main thing I want to focus on. But I also want to get a feel for what's going on. So let's first of all, start with I need to know timeframes. Who has to get out early? Anybody here have to get out early? Can you tell me?
Well, I have to step out in about half an hour or so.
Who's that? I'm sorry.
This is Amal. Sorry.
Yeah, okay, good. Hey, do you have anything to present for us then in the meantime?
About a 2-minute spiel on post-vaccine myocarditis, if interested.
Okay, that would be a good thing we could do. So let's first, right now, the only person we have on the other side of the pond right now is Fiona. So I'll take it from her and maybe go on to you. Then I want to get into this other stuff in depth. And we probably will have some visitors from CMS actually today, just so you know. One of the national directors for quality assurance is going to be on the phone and help us with the tackling this issue of the parking, et cetera. At least say, here's what it is from their point of view. And so I'm really grateful to have them on today. I don't see him yet, but hopefully we'll be joining us fairly soon. Okay, so let's start off. Fiona, let's do this. What's your timing like, Fiona? Can you be on for a while?
I can be on for about 40 minutes. I need to go about 10 past, whatever the hour is with you. It's 10 past 5 with us.
Okay, yeah, fine. Well, let's go ahead and because I'd like to make sure we get one of our Amal homages in here. So let's go with Amal Matu. So if you don't mind, tell us what you have to fill us in with.
Sure. So a few people had emailed about this post-vaccine myocarditis and pericarditis. I'm sure a lot of patients have been asking about this. My wife's a primary care doc, and she's got people that are really, really concerned about it. Looking at the numbers, it appears that the incidence of post-vaccine myocarditis and pericarditis is somewhere around 40 per million. And usually this is occurring within the first couple of days, perhaps a week, typically after the second dose of the vaccine. So interestingly, it hasn't been really reported much with the J&J single dose vaccine, but more with the Pfizer and Moderna, usually within the first week. It tends to be more common in young men ages 16 to about 30 or so. Pericarditis, on the other hand, is tending to occur a little bit later in terms of age. And with the pericarditis, that seems to be occurring with either the first or the second dose. So again, myocarditis usually second dose, pericarditis either first or second. Either way, the symptoms tend to be very mild, some mild chest pain, palpitations, shortness of breath, and it tends to be fairly responsive in the vast majority of cases to rest and NSAIDs. And I mentioned last week, I think the baseline incidence of myocarditis is probably about 20 per million. So the vaccine is taking you from about 20 per million to about 40 per million, so a mild bump. And I think that's worth letting the patients know about. And also just as a reminder that COVID-related myocarditis is far more common and far worse than the vaccine-related myocarditis. So everything's still, I think there's some really good things that we can tell our patients who are expressing concerns about this. And also I'm going to post in the chat the website for the CDC's information about post-vaccine myocarditis and pericarditis. They've updated it just within the past week or so. And that might be a good website to just keep track of for this particular issue.
So a good question is, what's the baseline noise of pericarditis or myocarditis? Let's see, what's your baseline consideration for pericarditis at this time? Because remember, a lot of this showed up in the spring, and granted, that's when they were getting their vaccinations, but that's also the time of year when people usually get, young men, for example, get a myocarditis or pericarditis.
That's about 20 per million.
Okay.
So this goes up to about 40 per million. So it's not a huge jump. It's a doubling of a very, very, very small number.
And probably an indicator of a good thing. Someone who studied that for a long time, interestingly enough, is on the line with us, John Jew, right? Didn't you do some of your work early on those on these kinds of native, not vaccine-related myocarditis, right? Any reaction to this, John?
Yeah, thanks, Paul. Yes, I did Coxsackie B3 and B4 myocarditis research here as well. This is behaving a little bit differently. B3 and B4, they're actually different from a phenotype point of view. They actually invade the heart tissue. This sounds like more like a vasculitis and not direct invasion, as almost suggested.
Yeah. Okay, cool. Well, good. That's great. Thanks for that perspective as well. I appreciate it. So that's it. So anything else to add then, Amal? That was great. Thanks for the good review and also keeping us up on top of. Very eagle-like of you to do that. So as usual, doing a great job for us. So thank you so much. Let's quickly move over to England and see what's happening in the UK. Fiona, what's going on there?
Good afternoon, everybody. So yeah, we're continuing the gradual relaxation of restrictions. We're still seeing the Delta variant as the only show in town. We had a peak which peaked on about the 22nd of July and has been falling off. So the peak was 34,245 cases across the UK, and we're now seeing 21,636 or so a day. Around about 146 deaths within 28 days of a COVID diagnosis. In terms of vaccination.
Yep. Fiona, can I interrupt you for a second? So this interesting thing is one of the things that Mike Osterholm was telling us last week, I think, was that they were seeing these peaks like with you or in Israel, et cetera, and then they're going off like this. So is that a good thing? Maybe that's what's going to happen with us, that we'll have a big peak and that it'll fall off, et cetera. Was there a reason why it fell off? Was there actions that were taken? Well, my impression is, if anything, there was a loosening of restrictions, right? So I just want to know is that just something that the Delta virus does, or is it some intervention that you also did?
I think the intervention was called Euro 2020.
Okay.
So we had the what you call soccer and what we call football. So we had the big football events, and we had the semi-finals and the finals in England, and a number of people came in to watch those, some big gatherings in public, as well as at the football stadiums. And we think that's what caused it. The big relaxation was on the 19th of July. So in advance of the peak, we're seeing a bit of a plateau now. And that's probably because we have relaxed things quite a bit. So people are out and about a lot more. You're still expected to wear a face covering in shops and on public transport, but not everybody does.
So was this a kind of a penalty shot with the Euro 2020? I had to rub it in, so to speak. All right, let's segue over to the vaccines then. Okay, go ahead.
Okay, the vaccines is still a pretty good story. So across the whole of the UK, we've vaccinated 89% with their first dose, and 75% have now had their second dose.
Nice.
now vaccinating all over 12s or 12 to 18s who are vulnerable and offering the vaccine to 16 to 18-year-olds. In terms of the new cases, the ones that we're seeing are the 18 to 30-year-olds, fewer now in the over 60s. We're seeing around about 750 people being admitted to hospitals. ITUs are a bit overstretched, but nothing like they were in the earlier waves. And what we're now preparing for is an upkick in the bronchiolitis cases. We've seen a significant surge in the northwest of the country. Hasn't hit us down in the south yet, but we're expecting that.
What's the virus etiologically usually there for you?
RSV.
Yep. Okay. All right. Now tell us about ambulances, because one of the themes we're going to talk about today is our ambulances being, kind of overwhelmed, and also lack of availability because they're being parked at the hospitals. And we're going to talk about that in about 2 minutes or 3 minutes, I think.
Okay. So yeah, we have significant hospital handover delays, particularly in some parts of the country. It's not so bad down in the southeast. We lose somewhere in the region of 150 to 200 hours a day. We have two particularly bad hospitals, one in Kent and one in Sussex. But our major problem at the moment is an increase in demand and a decrease in our resources, because we have got a significant number of people who are either off sick with COVID-related illness, be it long COVID, or they've been pinged by the app. But we've also got a number of people off with stress, anxiety and depression, particularly in our control rooms. So we are finding it very difficult to hit our commission targets at the moment.
Yep. Okay, got it. And so from you, I'm going to jump over to David Purse real quick in Houston. And David, I don't know how long you have to be on the call with us. How long can you stay on?
I got about another half hour or so.
That's what I figured. So I just wanted to pump in. The reason why I'm bringing it up is that I have to just start our conversation about ambulance parking, is that David had a very clever way of handling this maybe 15 years ago, in terms of having his legal department threaten the hospitals with lawsuits for theft of city services when they maintain the ambulances staying there. And so David, are you having those problems today? I know that you've been out there dealing with the mask issues and various other things as the health director, as well as the EMS director there. So what can you tell us what's happening there in Houston?
Thanks, Paul, and hi, everyone. So yeah, we're dealing with the ambulances being held at hospitals again, in spite of, when we did that a few years ago and tried to get the city attorney to charge hospitals with a crime, they didn't have the political appetite to do it. So that never really happened, but it's different now. So the mayor is really pretty upset about this. Fire chief is putting his foot down. And so we've been meeting with the hospital CEOs over the last 2 weeks, and this has been coming to a boiling point. So now we have several hospitals in the area that have set up tents outside the ER, and they're going to use EMTs and paramedics, not from the Houston Fire Department, but from suburban communities around, basically to staff those. We'll be able to bring our patient in, give report to some of the hospitals are actually going to have a physician out there to take report from the EMTs and paramedics, and then we'll transfer the patient over onto an ambulance stretcher, somebody else's ambulance stretcher, or perhaps a hospital cot, but they'll be monitored by EMTs and paramedics from surrounding suburban EMS provider agencies who are going to get paid to do this. So the upside is that the EMTs and paramedics probably cost less than a nurse. There are no nurses available in the Houston area, and we'll be able to get our units back in service quickly. The problem that is going to develop is that not all hospitals are doing this. And so in the well-honored tradition of no good deed going unpunished, I foresee that the hospitals that do this will get an increased ambulance load, and those that don't do it will probably see less, because they're going to continue to hold ambulances hostage. And I pointed that out this morning. And the fire chief is, regardless of what the hospitals do, we're putting together a policy. The details are a little sketchy right now, but when the Houston Fire Department has less than 25% of the fleet available to take the next 911 call, a radio message goes out to all units saying that we're in what they call EMS resource management. And that's a signal that everybody who can get back in service needs to, and supervisors need to find out what everyone in their command is doing and get them back in service. What will change in the future is that when that radio signal goes out, the radio message goes out, if you're in a hospital and you have a stable patient, you are to get them off the stretcher, and you can put them on the floor if you want. You put them in a chair in the waiting room, put them on the floor, put them behind the desk at the nurse's station, wherever you can put them. You are under an order from the fire chief to get them off the stretcher and get back in service. So the hospitals have been forewarned that this is coming, and now they're all of a sudden they're finding these tents and EMTs and paramedics. So anyways, that's what we're doing here.
Yeah. And David, would you be available on Thursday at 8:15? I have a meeting then where people are asking this very question specifically. So I was trying to see if you might be available at that time. Do you
So
have-
I won't, Paul, afraid I won't be available then.
All right, I'll try to figure out. I'm going to do the same thing with Glenn Asada and come up with. We're going to hear from him in a second about what he's doing. I just wanted to give everybody a perspective where David's out there, okay, and being pretty aggressive about it. And then Peter, just so you know, Peter and Debbie, Steve Shaw wants us to look at what we're going to do in Broward, and we'll talk about that. But to sort of set the tone for this a little bit, I wanted to bring in someone who's really kind of near and dear to me in many ways, is David Wright, who's on the national level, a person who's a director for looking at, I don't know what the exact title is, David, at CMS, but a director for quality of safety for your patients. And you've worked in this area, and this is one area you're familiar with. In fact, even was collaborated with the Eagles about 15 years ago when we put out a paper on this, which we're going to try to forward to you. And can you weigh in on this a little bit so that we know what kind of teeth we could put into it from the EMTALA level? So
yeah, sure. Thank you. And it's great to see you all again and to visit with y'all. Couple of things. Yeah. So I'm with the Centers for Medicare and Medicaid Services, and I'm the director of our Quality Safety and Oversight Group. And so we have responsibility nationally for the Emergency Medical Treatment and Labor Act and its oversight and enforcement. And we had issued a memo, probably 20 something years ago at this point, dealing with this issue of parking of patients, and really trying to help navigate the line of responsibility between the EMS providers and the hospitals. And because we're a hospital-based jurisdiction, our line pretty much rests with the hospitals. And so we issued this guidance, and it's been incorporated, and I sent Dr. Pepe a link that he can share with you all that explicitly states what our expectations are with regard to patients presenting via EMS and being told to wait. I think Dr. Peirce outlined, some interesting strategies, and I think, but the key thing that he said at the top was, to have those conversations, and what we recommend is to have those conversations, whenever you can, rather than arguing over a stretcher and a patient as to who's going to take them. But the bottom line is that when a patient presents to a hospital requesting emergency treatment, whether they walk in or they're brought by EMS, that triggers the EMTALA obligation for that hospital to take control and manage that patient. We have some kind of wiggly language in our guidance to account for mass casualty situations or other things where kind of common sense would indicate that everyone's doing the best they can to really triage and deal with patients. But the bottom line expectation is that you're not an extension of the hospital's emergency department. You're the ones who are bringing those patients there. And once they're there, just as if they get an influx of people wandering into the emergency department on their own, they can't just ignore them. They can't just think somebody else is going to take care of them. And so I think we continue to recognize it's an issue. Unfortunately, from a regulatory point of view, we're a fairly blunt instrument. We're not a model medical system, but we are more than happy to continue to reinforce hospitals the obligations that they have when patients present, that they provide a medical screening examination, and that they're seen in accordance with whatever triage protocols they have in place and what obviously they're dealing with at the time. But I would rather take more questions from you all. So I'll kind of stop there and see if y'all have any questions.
So I'll start off with a couple things. The first thing is the caveat is that what we'll talk about in a second is technically when we sort of cross the threshold and they know we're there, we could actually put them on the floor like David said. Ethically, we all feel that we shouldn't do that. And we need to do something along those lines. But I guess if you have to get heavy-handed at a point, because we feel sorry for them. There's nursing shortages, there's all that. So we work with them closely. So there's those kind of dilemmas, but we do have to come up with some solutions. And that's a little bit of what we're talking about. So one of the first things is, what would you say is the crossover to that? Okay, it's their obligation. Is it when we actually get on the hospital property? Is it when we walk through the door? Or do they have to know we're there? So can you talk about that one first?
Yeah, it's technically, as soon as you're on hospital property, that obligation kicks in. We want to be realistic though as well. They need to be aware you're there. And you know, one of the driving triggers is a request for care, whether that comes from EMS or the patient themselves. And so I think while, you know, we had during Ebola and other times instances where the units were actually had to wait out in the parking lot or off-site a little ways, you know, we reinforce that it's once they're on property and again, once they're aware, then that obligation kicks in. But traditionally, we're looking for when the actual presentation is made with a request for care, which again can be done, you know, as soon as the EMS rolls up or once you cross into the emergency department.
Right. And then in theory, part of it is if they're not making eye contact and all that, they can't use the excuse that we're not, yeah, that, you know, they know you're there. So that's basically it at that point in time. So that's in a sense a request for the. Let's go to a question from Dr. Sandy Schneider. So, you know, David, Sandy has been a person who's been just the president about every emergency medicine organization for Society of Academic Emergency, the American College of Emergency Physicians, and a former chairman of emergency medicine, longstanding, and has been a leader for us. And she's now the senior vice president, right? No longer the AED, okay? The senior vice president at the American College of Emergency Physicians. So the highest rank in their administrative organization. She's the highest ranking physician there. So she is in charge of clinical affairs. So I just want to make sure there was a proper introduction for her. And go ahead, Sandy, you had a question?
Yeah, I have a question. It took 10 minutes to introduce me. Sorry, Dave.
Yeah, okay, you're off. You're cut off.
Yeah, so the issue clearly that we're dealing with here is EMS. But then there's the issue that happens as soon as EMS drops it off. So it's fine if EMS drops off the patient and the hospital takes responsibility. But what we're hearing from members all across the country is that things are worse than they've ever been. And we know that things have been bad in the past. 70% of our docs say boarding is at an all-time high in their emergency department. Most of them now have stopped seeing patients in rooms because the rooms are taken up by patients. So they're seeing patients in waiting rooms and hallways. There are no more rooms. Rooms are now inpatient beds. ACEP has met with the American Hospital Association, with ENA and ANA. Interestingly, ANA and ENA tell us there is no nursing shortage. Now that was a week ago, so hopefully they have actually thought about this for a while, because the answer to that was somewhat unbelievable, because we're hearing large scale nursing shortages everywhere with lots of closed beds, and then the patients brought to the ED. In terms of the American Hospital Association, they basically said to us they really didn't have any ideas, but they were willing to at least continue the dialogue. So we're going to be talking with them again in another week or two. I reached out on our listserv of all of our members and asked if anyone had solutions, had a solution that, you know, worked. And so far, all I've gotten is a whole bunch of people venting on me about how bad it is. So is there anything that CMS can do to help? I get it, you can help with the EMS, but EMS would be solved if we could help with the next problem, which of course needs the next problem to solve, which needs the next problem to solve, because they all the hospitals keep pointing at long-term care. So I'm sorry, that was a very long question. And I'm hoping you can, and after you do this, you can, solve world hunger, okay?
But it is fascinating. They're unaware of what's happening with the church. And to David, do you want to respond to that? And then Kathleen, Yancey, I may just use you since you're a hospital, a leader and nurse there, so out in Washington State. So be prepared. But David,
Yeah,
you want to respond to that?
Yeah, don't have a lot of immediate answers. We have done what we can with our 1135 waiver flexibilities to allow hospitals to, set up alternate locations. We've allowed, at least for reimbursement purposes, relaxation of our whatever licensure requirements we have in place for people to be able to come from out of state, but that doesn't necessarily really get to nurses too much. But we really have tried to do what we can. I will say that we continue to see a lot of hospitals that, and maybe your experience is different, but usually canceling elective surgeries is one of the last things that they'll do. So we're in last year we were a little more prescriptive about elective surgeries. I think I can't speak to what will happen. I really don't know, but might get a little more push there as well, because it is hard to house people in the hallways while you're still doing hip replacements or knee replacements. And so I think that's something. I'll just address two quick comments I see here too. One is that remarkably, the American Hospital Association has not raised this as an issue to me, but I do talk to them regularly, and I will be happy to raise it on your behalf to them to make sure that they are aware and recognize the obligations, and certainly see the note about diversion too, which has been a longstanding issue that it really is a request, and that's why the obligation for the hospital starts when you roll onto the property, whether they said that they're on diversion or not. So again, and I will just say, and you all know this, that what we don't want to do is have the issue necessarily be forced. I think as we're hearing, sometimes it has to be, and that kind of wakes people up to the seriousness of what's happening. But there are fairly objective expectations and regulatory obligations for hospitals, both with regard to when EMS arrives and what they need to do when they're there. So more than happy to reinforce that to the American Hospital Association and Federation of American Hospitals and others that we talk to fairly regularly on a national basis.
I was going to say is that one thing that just as a FYI, for example, in Florida, we just try to get rid of the language of diversion and maybe call it critical capacity or whatever. And if you have a functional problem like your hospital's flooding or something like that, or there was a crash, that may be a different thing. So we are trying to get away from the concept of diversion and just say they're announcing they have critical capacity. But the answer is that's for our point of view. We see that as a request because they're busy, and and I assume that you guys are in with that. Let me jump over to I'm going to two people. Can you stay on, Candace? Pinetta, can you be on and make a comment about this in a second? Candace, are you there?
Yes, I can.
Okay, good. First, let's go to Kathleen out in Walla Walla. Okay, and so here you got a smaller community hospital in a sense, although a major referral center, but relative to some of our big cities. But what's going on there? You have no nursing shortages out there, Kathleen?
No, I'll tell you what, this is a real head scratcher for me. And I'll got to tell you what I told my boss, what was said last week, that the ENA was saying that there isn't a nursing shortage, and we both busted up laughing because I challenge you to find one single hospital who agree that there is not a nursing shortage. There indeed is. In fact, we can't even find travelers. So our hospital, I was mistaken. We are 80 beds, not 70, and we are full all the time with boarders in the ED. We don't have the issue of EMS in the ambulance bay or waiting inside the doors to offload patients. Back when I was the ED charge nurse, I started something that they have continued. If we have patients who have already been imaged, they've already had their labs done, they're waiting for imaging results, even if they have an IV, but they're hemodynamically stable, they get to wait for the results in the waiting room to make room for the worthy EMS patients. If the EMS patients really are low acuity, we're triaging them right out to they go straight from the ambulance bay right out to triage, and the triage nurse can decide if they're worthy to come in. We started to have that issue, and I just said, listen, why are people waiting for results and perfectly stable when we've got people waiting for beds? So we started doing that, and it has worked well for a hospital our size. But there is indeed a nursing shortage. There's no doubt about that.
And then how about on the border side? And Eric, I'm going to touch you in a second, by the way, Eric Carney, after a couple other people. And part of this is informational. I want to get out to David so he gets perspective as well to Mr. Wright. But one other thing I want to ask you about is, are you still having trouble getting people out, like back to nursing homes or transfers and all that kind of thing? You're still having a problem with that?
Absolutely. We have a nursing home bed shortage, especially if they have a COVID diagnosis. There are a couple of nursing homes that take COVID patients, but only a few because they only have a few rooms. And so, yes, we're having a hard time dispositioning nursing home patients back to the SNFs. Borders are, at least we're less than 24 hours on most of our borders now. We are ready as soon as we hit a certain capacity. And I'm not exactly sure what that is because the people down Tiptoe Alley, which is our administration hallway, won't release this information. We are ready to stop elective surgeries if we need to house patients in same-day surgery.
All right, let's go on over to Memorial Hospital that supplies our CME, and the CME for today is 12996, 12996. If you're on the Florida call, 12997. And the person who gets that for us is our dear friend Candace Pineda. And Candace, Randy, who's on today, and we can have him mention anything, but told us last week that you guys were about to run out of oxygen. I wonder if you did, number one. And you have a large tertiary care center, trauma center, et cetera, in South Broward County. And so tell us what the status is there and our wall times out to the 2 or 3 hours we're hearing from different places.
So we did not run out of oxygen. We had a police escorted additional supply come in. And so we have some, but it's something we have to constantly watch because as everybody mentioned, space is an issue. Nursing is an issue. We're getting creative with space. Our employee and visitor cafeteria has been taken down and will be replaced with beds so that we can make it into a quick care area because we're just out of space. We've used our conference center, we've used our auditoriums. It is all full with inpatient beds. And, you know, it's heartbreaking. It's not our expectation to ever have EMS wait. There's just not physical space nor people to, you know, attend to those patients. So it's been quite a challenge. We've pulled my team on the back end that does, you know, peer review and paperwork to come back out and be nurses. And so they're rounding in the ED and they're supporting all the nurses are there. And your ED nurses are not able to just do normal work for emergency care. They're becoming inpatient nurses and ICU nurses. And, you know, our patient ratio was 1 to 4, 1 to 5. It's now 1 to 7, 1 to 8, because we're stretched thin in so many places. So it's physical space challenges. It's, you know, bodies to watch the patients. You know, how can you survey who's sick when, you know, you're just pulled in so many directions?
Yeah. And so if you had a message you wanted to get out to the world, is it more a kind of thing, please get vaccinated, please wear a mask, or are you just not in a position to say anything about that? But if you had your way, just as Candace, what would you think at this point in time?
Absolutely. You know, 98% of all of our inpatients sick COVID, we have 600 plus across our healthcare system admitted, and 98% are unvaccinated, and some are wishing they were vaccinated. So, I mean, obviously that's the easiest choice. In our state, the governor's decided absolutely no mask can be mandated anywhere, including schools. And so that's presented quite a challenge. I just ask people to be educated to at least wear a mask. I know, you know, not to be forced to, because it's the right thing to do, and definitely get vaccinated.
All right. Well, Randy, anything you would add to the report from what's happening, since Randy's got the emergency department there and Hollywood Fire Rescue?
You know, I'll echo everything that Candace said. I mean, the hospital's really in a crisis right now as far as the number of patients across the system. We've got close to 700 COVID patients in inpatient units. The one thing that I would mention, and something that we're doing, and I think, you know, I know you guys have sent out a lot of information regarding pre-hospital treatment, but monoclonal antibody infusions are a key piece that I think, you know, we got a little bit behind on. You know, the EDs have the ability to infuse drugs, you know, and a lot of the infusion centers are overwhelmed. So right now what we're looking at is really trying to integrate infusions into the ED visit when we have a patient that meets criteria, you know, to capture that patient in real time, you know, and not try and schedule them somewhere else and you know, figure out how to get them an appointment or get them into an infusion center. I think the data is clear that if you give the drug very early, It reduces hospitalization, reduces mortality, and there's sub-Q administrative ability too. So there's a lot of ability to utilize that more. And I think we've been underutilizing it in general in our ERs.
All right, let me switch over to Erica Carney in Kansas City. You have been so lucky not to have any COVID cases in your area, correct?
Oh my. Just here, you know the difference. So I can share my brief report that I shared that was shared this morning. So as some of you guys know, not only am I the city medical director, but I'm also the Region A medical director. And so we meet weekly with our elected officials, all of our EMS agencies, hospitals, et cetera. This morning's message was very clear that this for us in our region is not business as usual. For hospitalizations around the region, we've grown from 25 a day to over 150 a day, with deaths exceeding over 60 in the past 1 to 2 weeks, although the reports on those are delayed. Our hospitals are at an unprecedented fullness that we've never seen before. A lot of this is contributed to the fact of staffing shortages, as everybody else has voiced here. With that in mind, the HHS and ASPR had a meeting with our state mutual aid coordinators, and we got a FEMA strike team delivered to Region A. I know Dr. Gilmore is on to potentially speak about the St. Louis side as well, although we're West Side, best side. That's what I always say. I have to give him a hard time. So there is conversation about alternate care sites, but with poor staffing, that is not the best solution at this time. Our steepness of our curve is 85% of where we were at our previous worst peak in November and December, and we cannot accept any outside transfers from surrounding states, including Iowa, Texas, Oklahoma, et cetera. Unfortunately, the fourth parallel trend that we are seeing is the mental health and mental ill-being of our frontline providers. This includes hopelessness, death, anxiety, depression, stress, insomnia, distress, PTSD, and unfortunately, moral injury. It's important to note that moral injury is not a behavioral health condition. It is an ethical concern and dilemma. This is significantly worse in our frontline providers, our emergency department providers, et cetera. So with this in mind, there have been some city ordinance changes that have occurred per the state regulations and state recommendation. That has led, as Dr. Pepe knows, to some pretty severe political outcomes on top of this. But I'm hopeful that the patients will be at the center of all of these discussions as we kind of move forward. So I can pause there.
So Erica, thanks. Can I ask was there a positive, negative test on someone we know about, just out of curiosity?
Yeah, my coworker, as Dr. Pepe knows, came down positive, and we were not wearing masks in our office. We were outside of our office. So I am on quarantine this week. And while Dr. Pepe was in town, I was also on quarantine, unfortunately. I am pregnant, so my OB doctor has already put me on some aspirin, and then I'll get tested again the end of this week to make sure I stay negative.
Yeah, I hope so too. I'm sure you'll be okay. It sounds like if your first test was negative, that's a good sign, you know?
Yep.
So, hey, I do actually, now that you remind me, I heard that they're going to quarantine about 50,000 people who came over from the Kansas side. Tell them about what I'm talking about there. Okay. So.
Yeah, the Garth Brooks concert that Dr. Pepe brought to town, our super spreader event on Saturday night.
Exactly. Yeah.
But this was also exacerbated by Sturgis. And then we have the Guns and Hoses as well, which is very well attended by many people in the city. So red versus blue.
What happened is that the stadium, Arrowhead, is right, it's on the Missouri side, but right across from the Kansas side. So obviously a lot of people came over from Kansas to the concert.
That's correct.
And there's a rule that you can't go to a mass gathering out of state where there's more than 25 people, right? This was like 70,000, right?
Yeah.
Yeah. And so they all have to quarantine over there. I'm sure everybody's following that, right?
Yeah, the good news about this weekend though, and specifically for that concert, Dr. Pepe, with your involvement, my crew's, KU's involvement, and DMAT, our state disaster team, we only had 7 transfers out of the stadium, out of 70,000 attendees, so.
So first of all, just sorry to interrupt everybody else with our personal note, but I just wanted to know, Kevin Wheatley and his team, and of course, Jen was fantastic, right?
Yeah, Dr. Watts, yeah.
Together. And then I had a great time talking to the residents from KU. I actually gave them some lectures, so it was a good time. I did come up for those who are interested, I developed a new detection system for Delta. And what happens is that where I put this on, you can see where there's a bright light. That's where there is a thing of Delta. Let me just show you here real quick. Here we go. This is anywhere you see a bright light, that's bright light. All right. So anyways, there you go. So that was my
You'll see how,
huh?
you'll see how Kansas City loves their masks in that clip there.
Yeah, and they were singing loud, so it may end up being a super spreader event, I'm afraid. So it's interesting. That's part of the reason why I was there, to sort of keep eye on that and say what they should do next. All right, well, any event, so thank you again for your crew, and thank you for your help, and I'm going to stay in touch with you this week if that's okay, right? And for those who again want, David actually put his email there, which is very nice of you to do that. His email's on the chat if you want to find it, etc. And so that would be very cool, very great of you to do this. We hope this was going to be also an educational experience for you. Is anybody out there? Hey, Peter, can you give the Peter and Tevi, because there's a lot of the thing that got me on this today, and I'm going to go to Glenn next in New York, but got me on this because you're having long, as they call them, wall times or parking times. What are they getting to? Like 2 hours, 3 hours at times? Is that right?
Yeah. So we are having significant issues at most of our hospitals, to the point now where we've used a different strategy. First, we were asking the hospitals to provide us information from their end, and then we said that's not a smart thing, so we turned it around. We all use ESO, so we've now generated an ad hoc report through ESO that will automatically send to our EMS chief every 6 hours. And then that automatically sends to the battalions every 6 hours.
Yeah.
So we really have like a real-time report of what's happening on the wall, and then we can kind of be smarter about where we're transporting to. I mean, in Davie Fire, for example, I have 9 hospitals that I can transport to. So we just have to be smarter about where we're going. Once we're on the property, unless I make a phone call, a personal phone call to get a favor, oftentimes it's basically we're just out of luck, and it leaves the entire city at risk. So that's the status. It's blowing up here. Randy will tell you, Candace, Jim Roach. It's not good.
So will you be on the call with me on Thursday then? You'll be there, right? We have our 9 o'clock meeting with the MS committee, and Steve's asked me to talk about this, but I'd like to, maybe you can help relay, and maybe we can help run some clips of what David was doing and so on. And then next, what Glenn is doing. If you could help me with that, I'd appreciate it. Will you be available for that?
Yeah, I'm on vacation here. I'm in Santa Barbara, but I would try to sneak out of the hotel room and join the meeting.
Yeah, I have ways of protecting you from the other individual. So okay, so we'll take care of that. I'll distract her. Okay. Hey, Glenn, let's talk about what you've done about this in New York City. You've had this problem. You presented this at Eagles 3 years ago. And how have you been handling when your ambulances are tied up at hospitals and so on?
Yeah. Hey, good morning, good afternoon, good evening, everybody.
Glenn, for those who don't know, Glenn Estada is the medical director for New York, FDNY, but chief medical officer, because you got a bunch of you floating around, right? So, but go ahead, Glenn. Sorry to interrupt you. Go ahead.
Yeah. No, our ambulances have been held hostage by the hospitals, ever since the inception of the system, I'm sure. And it definitely is continuing. So we always wanted turnaround times to be about 20 minutes initially. Then we tried to be more realistic, went to 25 minutes. And quite honestly, even pre-COVID and such, 35 to 40 minutes. It was a big problem for us. And, we always know that it goes both ways. we blame the hospital blames us. You know, I always joke, maybe if you started getting less attractive nurses and staff, our crews would be easier to get out. You know, so we've been joking on that, but you know, the hospitals, we blame them, no bed availability, you're not triaging them fast enough. They blame us to say, well, your crews aren't getting out fast enough. And there's a lot of truth. Hot days, cold days, you know, our crews, nobody gets paid by the call. So there's no incentive for them to go back out there. So it definitely goes both ways.
And of course, it's not everybody's the same thing. There are always 10% of the people will do something, you know, versus 90% of the people that are doing it right. Yeah. So it's like,
right,
yeah.
Absolutely. And we've heard from crews that, hey, you know what, I tried to do the right thing, you know, transfer my patient over, got back in the field, only to now get the call that the crew in front of me should have gotten. And now I got this, you know, 300-pound sick job that I had to carry down you know, so after a while, it all levels out. So for about 10 years now, we started a redirection policy. So we have diversion as a courtesy that we will provide to hospitals, and it's case by case. But we were finding that our crews were there. So we put in a policy 10 years ago or so now, redirection, where we actually will put the hospital on redirection or diversion, where we will not bring ambulance patients to them anymore. That sits well with the ED docs, those of us in the pit. That's like, great, less cases. But the administrators are not happy with that. So what that does is gets the administrator to now find beds, get the triage process moving faster. So initially we did this with just a blanket rule, 3 or more ambulances in the ED bay for longer than 20 minutes, then automatically through our computer assisted dispatch, that hospital is placed on redirection. But with 60 or so hospitals, we realized that that one size fits all does not work. So Kings County, which is one of our bigger hospitals, 3 would mean that they'd be on redirection almost every 10 minutes. So we had to come up with a formula to say, okay, at Kings County, it's going to be 6 ambulances greater for 20 minutes, and in smaller hospitals, 3. So every hospital now, after about a year of the initial program, so 9 years ago, we tailored a better a plan as to when. So that is still in place, and the computer assisted dispatch actually does it automatically. The administrator is notified, and then they start finding beds for us. Then we tried a fast track triage program where we realized that there are quite a few patients that are very, very stable. They didn't need medics, they didn't need EMTs, they really needed a cab, but they called us, so we're there. And to stand in the same triage line now 10 deep just didn't make sense. So we asked the hospitals, the health and hospitals, the city hospitals, to say, hey, listen, can you have a separate fast track triage area? And we came up with parameters to say, here are the patients that qualify. They have to be ambulatory, they have to be stable. You know, these things that are quick type fast track patients. And so we wanted them to have a dedicated fast track triage. So instead of standing 10 deep, they can move these patients that are ambulatory to the fast track side, get them through faster. That worked initially. We also assigned a line of duty injury EMT to the scene of these hospitals so that when crews came in, they would say, hey, that patient seems to meet the fast track criteria. Let's move them over to this end. Well, what happened was the union said, absolutely not. That's not in their job description. So we had to pull that EMT out. Then what was happening is we had problems with staffing issues at these hospitals because they couldn't have a second fast track triage area. We asked that a nurse kind of stand by to direct them to go to fast track or stay in the line. That also didn't work because that nurse that's directing patients today could be in the fast track triage area tomorrow. And so if they were friendly, they would say, no, stay in this main line. You don't need to go to fast track, because they realize that tomorrow the roles were reversed. And if you send too many patients to them, then, hey, she or he's going to do that to me tomorrow. So it ultimately didn't work in that vein. However, taking that as a basis, we now have at, again, a few of our city hospitals, 2 EMTs and a supervisor assigned with our patient care report tablets, so that for stable patients, the supervisor will direct the 2 EMTs assigned to him at the ED to get the information transferred to their tablets, so that now that crew can sit with the 3-4 patients that are stable awaiting triage, and the crew that brought them originally can actually be cleared to go back out in the field. So that was working very well, to a point where some of our private hospitals said, hey, we'd like to do that as well. We told them that then you'd have to pay for the funding because this came from a city budgetary issue. So some were interested in doing that. Now, it seemed to work well, but our crews are savvy. They're smarter than us. So they started to realize, hey, this hospital and that hospital has the supervisor and the 2 EMTs there. So let's go somewhere else. So they would tell the patients, even if they wanted to go to hospital A, you know, hospital A is really busy today. And I think hospital B has steak and turf, you know, surf and turf for lunch today. Maybe you want to go there. And they were smarter than us and would bypass those hospitals and end up going somewhere else. So that's currently what we're doing. And, you know, surprisingly, with COVID, obviously we were crushed. After COVID, with the volume being so low, our turnaround times got better. And even though our volumes have gotten back to kind of normal now, our turnaround times have been probably 25 to 30 minutes now. So we're lucky in that. But like everyone else, we're getting calls of the request for diversion for nursing shortage, staff shortages.
All right. What I want to do is switch gears and start going over. Thank you very much, Glenn, and we'll talk later if you don't mind. The one thing I do want to do is start going over to our infectious disease reports from John and Eileen. But first, I did, since we referred to them before, just see what's happening in St. Louis, because there's been some interesting political aspects to it as well. But what's going on what's happening in St. Louis, Scott, if you don't mind telling us?
Sorry, Paul. A little bit of delay in the network today at where I am.
Yeah, me too. That's what my brain is, a little delay in the network. Okay.
Anyway, so the political bickering continues to play out. The county executive recently asked, and they will vote on it tonight, whether the county council will reinstate the mask mandate for the county. Currently, the judge who is assigned to this put an injunction against the enforcement of the masking policy, and it's on the docket for review, but it's not on an expedited review. So it'll still take a while for it to play out. And as usual, the show continues on in St. Louis.
Yeah. Okay, got it. So yeah, I can't wait to get back and enjoy it in person with you sometime soon. Thank you, Scott. Then, hey, anybody else have anything else to add before I go to infectious disease land? Does anybody else have anything else to add to the discussion about you know, the ambulance parking system or boarding, or, you know, inability to get them out of there, let alone us inability to get them in there? Any other thing to comment to, or let's say clever solutions that you've come up with to deal with that anywhere?
Hey, Paul.
Okay, Angus, and who was the other one?
Scott.
Which Scott who?
Scott, Mark.
Oh, Scott, Mark. Okay, good. So let me go to Angus, and I'll go to you, Mark. Okay, thanks.
Thanks, Paul. So we had a great protocol in place where we had both hospital voluntary divert as well as EMS bypassing them if they were holding units, similar to Glenn, but actually even a little bit more aggressive than that. They held a unit for 20 to 30 minutes. We'd shut them for 2 hours to all ambulance traffic. And that had us 98% 15-minute or less drop time all the way through up until pretty recently. We're now, I think last week we had a couple days where we lost 150 hours of wait time at our hospitals. We actually deployed last week a very similar strategy to PERS down in Houston. And through those discussions with the hospital, we went from about 120 hours a day of lost time down to less than 50 within a day or two, without actually even turning it on. We just had the discussion and put it out there as this is our next step, and we got a lot of movement from the hospitals.
Okay, I mean, at first glance, I would think if you weren't bringing any ambulance traffic there, they'd be go, oh, thank God we're not getting any ambulance traffic.
Well, that's during regular operations, yeah. So that's the hit them financially during regular operations, but we're way beyond that now.
Okay, got it. We're way beyond birthdays. Okay, good. Well, let's move on over to Mark Escott in Austin. Mark, what's going on there?
Thanks, Paul. Like the rest of the South, you know, our hospitals are very stressed and out of ICU beds and hospital beds as well. You know, I spent all weekend on the phone with healthcare systems about diversion requests. Ultimately now, to avoid the call from the charge nurse, the individual ER, those requests go through the CMOs to the system CMO and then to me. And we do a 2 to 4 hour, please avoid, if you can, page out to the crews. One additional thing that we're discussing now, and I'm curious if any other regions are doing it, is utilization of the NEDOCS and CDOCS scores to distinguish the severely overwhelmed to the dangerous overwhelmed facilities. And I'm curious if other systems have implemented that and if that's been successful at helping to triage diversion to only the most severely impacted.
Yeah.
We tried that 2 years ago and couldn't get traction from the hospitals to consistently use it. So we ended up having to continue to manage ourselves.
All right. Anybody else want to weigh in on this at all?
We're gonna hold fast on our new diversion, and if it gets bad enough, we'll just round robin. We don't want to ruin our long-standing program.
Yeah. Okay. And then Terry, you guys just outlawed the concept of diversion. We're not even using the language anymore. In our neck of the woods, right? But are your hospitals still parking the ambulances for a long time in Tucson? Oop, did I lose you there, Terry? I think you're not on.
Yeah, no, I'm here. I haven't heard. I've been hiding from the hospital for a while now, so I don't have.
Yeah, staying safe. That's a good plan.
Yeah.
Okay, good to think. Again, thanks for being on with us. We love it. So that kind of thing. We got to get back to it. All right. Well, then let's go ahead and move on. Anybody else has anything else to report on or talk about? We may send out a survey on if you have some particular things, but let's go ahead and get our it's time for our infectious disease report. And let me see. Oh, by the way, Sandy Schneider, anything else to add from the ASAP point of view?
Yeah, a couple of things. As I mentioned, we are going to be meeting again with the American Hospital Association. We'll probably try to reach out again to ENA and to the American Nursing Association. Maybe they just didn't realize last week that there was a problem, and maybe they'll get it this week. It's almost unbelievable to me.
And also make sure they understand there's no pipeline either. They're not going into nursing schools, right? So
yeah, the whole thing is an implosion that is happening. I was going to say that's about to happen, but it's happening. But let's move on to some more fun news in terms of workforce. As you know, we put out the paper on workforce has just been published. We are meeting with all of the large groups to talk. One of the issues was there was concern that a lot of the large groups are starting residencies, and that's going to dilute even further our workforce and give us more. Maybe we could use us as nurses. Anyhow, yeah, we could work for ENA. Anyhow, we've met with all of them and asked them what's going on, and basically they're saying a lot of the hospitals like HCA, and the tenant hospitals are very interested for economic reasons in starting residencies. And basically saying to them, either you start residencies or we'll find another group that will start residencies. And so we're coming up with a bit of a problem there, but we're trying to work through that. We are doing some other things to try to both decrease the supply and increase the demand for emergency physicians. Again, maybe they can use them as EMS. We could be paramedics, right? Right.
And it's fun. Reach is my cup of tea. I love it. So good.
Yeah, Research Forum was incredible. Thank you, Paul, for all of your incredibly hard work throughout that time. A lot of really good abstracts in there. And everyone wants to know, are we going to Boston? At this point, it is on, but it is under discussion, and I'll let you know. We will definitely have a hybrid meeting in Boston at the end of October. But whether there will be an in-person component on that has not yet been decided. And we're hoping that what Fiona saw in London and what they saw in Israel, which was that gigantic, that it kind of fell off fairly quickly, we'll do that in the US. I am personally not hopeful because of our vaccination rate. But anyhow, we'll let you know as soon as we know. But at this point, hotel rooms are refundable, airfare is refundable or is usable for the next year. It's not refundable, but and in fact, by the way, I even asked them and they said, actually, that 1 year thing, you have to use it within the year is not true. You can actually ask them for another year or another year. You have up to 5 years to use your airline miles. I can't believe this will go on for 5 years.
Yeah, well, but the good news is that Delta is now making room for a new variant, out there. So we'll see how it goes with these unvaccinated folks. Hey, Jim, anything to report from the IAFF or IFC, Firefighter Associations?
Yeah, very, very detailed call this morning with the biggest discussion being vaccine mandates and how they can be carried out. As you all saw, the military is going to mandate vaccinations for active military. They're anticipating FDA approval of the vaccines that will allow them then to fulfill their own rules. Canadians, the Canadian border was just open to fully vaccinated Americans. So anybody who wants to travel to Canada can now do so if they're carrying their vaccine passport. October 21 and 22 is when the IFC, IFF group are planning a hot wash. It may be premature at that point, but they're very interested in gathering the lessons from COVID. And finally, a lot of discussion about masks in stations again, especially in the hotter zones. Yeah. We made it through the FRI meeting in Charlotte a couple of weeks ago. It really wasn't much fun to be in Charlotte because everything's shut down downtown. Even the Westin had half of a restaurant open. And I'm interested to hear from AJ and others what's going to go on with our EMS meetings over the next couple months. Thanks everybody for the information. Your IFC and IFF leaders are waiting for leadership from us.
Okay. Well, listen, I do have to say, if you hadn't seen the chat, Sandy Schneider was asking if we travel to Canada, do we have to come back? Especially to certain states, right? So whatever. All right, and then Libby, I'm gonna come out to you after I talk to John and to talk to John and Eileen. But let me ask you this: is there anything to report of a note from the National Association of EMS officials, Mike?
Yeah, I hear you, Paul. Thanks. No real big updates from the organization today. Again, reached out back to Mary and Dia. I think the real only notable event though would be you can download the evidence-based pre-hospital pain management guidelines. They're now official. Heard back from NHTSA. They are up on the website, available for download. So feel free to check those out.
Okay, got it. Okay.
Hey, we did have this big conference in Indianapolis this week called FDIC.
Oh yeah, and then
shout out to RJ. I really enjoyed seeing their pre-hospital ECMO unit.
Okay, cool. Okay, good. Sounds great. Is that the picture behind you?
That is it.
All right, good for you. Thanks for putting that up. That's really cool. And just a real quick note, one thing that Kathleen was saying was that since the changes in law enforcement response to calls that might be mental health or social issues, our EMS transports have increased dramatically. And so just they're getting hammered with calls with the mental health hazards too. So just to keep another thing to throw in there, as if things weren't bad enough. All right, let's go on. And who would like to go first? First of all, let's go to Eileen this time first, and Dr. Smarty out of Miami. And then, hey, you were on with CNN just now. What did you report on?
No, they canceled my thing because Cuomo resigned. So they gave precedence to that, which is fine by me.
Who was it? Who resigned?
Governor Cuomo.
Oh, okay. I heard of him. Yes. That's right.
yes. So that's the story with that.
Okay, good. Well, you got bumped for Cuomo once again. Right.
That's it. That's a funny joke. Okay. All right. On that note, let me see if I can get you to see my slides again. Here we go. You see that?
Yeah.
Yes.
A lot.
So that's a lot. That's ridiculous. Look at this death number. It's just mind-boggling. I mean, we're 4 million new cases a week in the world. It's just, and the numbers in the US are horrible. And Miami-Dade, in terms of cases, Miami-Dade, I should tell you, has a population of about 2.7 million, now has more cases than Cook County, which is a county that has 5.15 million. Okay, so Miami-Dade is beating Cook. Yay. I think that's just really, really sad. And that's the truth. In fact, we're really in bad shape in Florida. This article just came out today in the Miami Herald talking about the report from HHS, which places our hospital use at having increased in terms of the average number of COVID patients from 55.7 to 65.7 in just a couple of days. And that's also being paralleled in the ICUs. And sometimes I get parents and other people complaining that, oh, well, there's only 27 cases in this children's hospital. That's not overwhelming. And it's hard for people to understand what these numbers really mean in terms of care, because the bottom line is that the higher the caseload, particularly when you're talking about these complicated, hard to manage patients that require all this infection control and all this extra attention, the more there are, the less care we can give each individual. And as you give less care for an individual, you have a decrease in the quality of care. And that's how more deaths happen and more problems happen. So this is the most recent profile by the CDC of the state of Florida. It's only gone up from last week, so that the rate of new COVID cases is now at 481. It was at 300 and something last week, if you'll recall. And here in Miami-Dade, we are deep into the bad zone, as you can see. These are our numbers specifically. So these are the numbers I showed you last week right here. And this week, and as of the 5th of August, the average number of positives per day has gone up dramatically in Miami-Dade, as has the 7-day average. And you can see how much higher the 7-day average is in Miami-Dade compared to the state of Florida in general. In terms of the 7-day case rate per 100,000 in the US, look at how much lower the US is compared to Miami-Dade, right? If you're looking at the this Miami-Dade County changes here, again, you see that everything is just simply getting worse. And let me just show you this real quick. So again, last week I showed you these figures. Now we're at 19.2 of COVID admissions per 100,000 beds. And I'll tell you the exact numbers that Peter Page from Jackson gave me yesterday. He said that there are 363 COVID patients in the general ward and 86 in critical care. And that's up from last week of 208 and 60. So in other words, a 75% increase in hospital beds, period, by COVID patients at Jackson Memorial, and a 43% increase in critical care. I think that speaks for itself. Everybody knows this stuff. Let's see what, oh, here, one more bit here is, I hate the way that we report things that are so misleading. One dose of vaccine is not the way we're supposed to be reporting things, but they try and make it seem as if this is a really valuable number, but it's not. The really valuable number is what is the fully vaccinated percent. And we're still not at a level of herd immunity, and clearly we're not, because our cases are rising dramatically. And another thing that's not obvious from that is the deficiency of vaccination in the younger population. So you can see that people from 12 to 29 really are not anywhere near as well vaccinated as, for example, the 60 to 65-year-olds, which have a much higher rate of being vaccinated. So those are some of the key things I wanted to bring to your attention. I'll also mention real quick about this report on pregnant women, because 17% of COVID-19 pregnant women have required hospitalization, and that's just nuts. And 121 have died of COVID. So I'll leave it at that and let you ask me questions or whatever.
Yeah, which really helps us a lot in terms of, and remember when I had the question come up a couple of weeks ago from somebody that she's pregnant, should she get the vaccine? And we all went, are you kidding me? Do you breathe, right? And so that helps substantiate that. So Eileen, why do you think this is happening? Is it all the immigrants sneaking across the border? Sorry, I couldn't resist, right? So,
Oh, my goodness. It's so mind-boggling how politicians elect to deceive the public
yeah.
and not confront a problem. It's you know, I was trying to give the analogy today. It's as if there's a hurricane coming to the east coast of Florida. It's looking like it's going to hit Miami-Dade, and they're saying, oh no, it'll probably hit Tampa. Don't worry about it. Don't get supplies.
Yeah. So yeah, I mean, yeah, well, whatever. Just it's incredible.
You know, it's nuts. Peter, it looks like you have a question.
Yeah.
I wanted to really kind of bounce off what you had just mentioned, with which I don't think a lot of people not in Florida are seeing. But I sent the other day in a pregnant lady who was having abdominal pain at 8 p.m. to one of our emergency departments. She wasn't seen until 4 o'clock in the morning. And so I think there are certain emergency departments who are choosing to just leave the patients out there. And then there are others who are actually going out and triaging them, and therefore maybe putting themselves more at risk. So I'm just wondering what other people are seeing, but I think that you can't leave people out in the waiting room for 8 to 10 hours and expect a good outcome. So I'm curious to hear from Randy and Jim and others, because I think we're in a dangerous position.
Peter, what you just said is absolutely on point and a huge problem. The other major health system here in Miami-Dade is Baptist, who informed me that they are running at 100 or 160% occupancy. They say that their urgent care centers have lines for people to get in, just like what you're describing, Peter. And some of the people that need non-emergency surgery are being completely delayed because of lack of beds. There's a shortage of nursing, there's a shortage of clinical staff, and the numbers are at or above where they were when we peaked last July.
Okay. Let's make sure we have enough time to plug in John Ju. And John, a couple of things that have come up. Maybe I don't know if you could discuss them, but for example, they've looked at the Moderna thing 6 months out, and it looks like it's effective. I'm not sure how they did that, whether they used neutralizing antibodies or how they came up with that concept. But can you expand upon that for us?
Yeah, can you hear me? I'm having a little audio problems as well. But the answer is yes, but I think if you look at the Moderna, the data is a little bit dated as well. And so it's not really against the Delta virus here as well.
Right.
So I think Moderna is accurate, but you have to look at the strain as well as the time that the Moderna trial was done. That's really important. Do you want me to continue, Paul, or?
Sure. And then I was going to say, it's like our little study that we did on the vaccinations, right? And the neutralizing antibodies, like that's fine, but it's it's not the Delta virus per se when we did that. So the things are in motion. And the other thing I said, I actually just sent an abstract in just for fun about our meeting, and said that we watched it real carefully. Everybody had to be vaccinated. We had some spacing and masking and all that. But we still went to restaurants together, and we still had to be on airplanes, and we still had to get on buses or Ubers or whatever. And that there were a lot of opportunities for exposure. And so we wanted to see how that went. So it turned out it was 100% safe in June, and Delta was the predominant strain in Florida at that time, but not like it is. And so now with national surges, and now with even further surges down in Florida, obviously, would that have been the same? Would it have been different, et cetera? So you're right to put it in context. A lot of the studies that come out, make sure you keep in mind when they were performed and so on. Okay, so let's hit it. Go ahead, John.
Yeah. All right, can you see my slides here as well? So getting back to the title slide, it's a very interesting way of presenting their scientific view. This is the earnings report as well. So it's sort of interesting. The Pfizer earnings report actually has some science in the earning report here as well. The 2 or 3 slides from Pfizer actually gives you, for the first time, I believe, the data on booster shots here as well. And they have actually performed, this is the phase 3 study, suggesting that the booster shot performed on 2 groups, 18 to 55 and 65 to 85 years old. And so there's actually 3 things. Number one, as expected, the booster in older individuals was not as high as in younger individuals. But more importantly, the booster actually started taking effect on day 7 here as well as maintaining effect. If you look at the overall, see in purple, against the Delta variant, there was a 5-fold increase in against the Delta variant with the 3rd booster. Okay, this is with Pfizer, and I expect Moderna to be the same. If you look at the 65 to 85-year-old, there was a 3-fold increase, 11-fold increase, sorry, as well. So even with the current vaccine, you're getting a very, very significant dose in the booster shots, especially for the older individuals that may be susceptible here as well. The second issue is that there's not a lot of data on the actual true breakthrough. CDC says, well, we're only seeing 10 to 15% true breakthrough here as well. This is from the UK data, and the real reason for paying attention, as I said before, is they have Delta strains here as well. And this is self-reported studies looking at the REACT-1 from the UK, and their assessment here is that the protection is anywhere from 50 to 60% against basically getting COVID. So most of the data is quote unquote against getting serious disease, but this is one of the few studies that has population based against COVID. We're seeing, my services are seeing a significant amount of breakthroughs. Unfortunately, mild. I have 7 out of I would say 800 with breakthroughs so far in my cadre here as well. So this is the other thing, as Eileen suggested, that the viral load is very similar to in vaccine recipients. As you see, the CT values are very similar to what we have, and obviously not vaccinated is lower than the CT values here as well. Then finally, there's a risk of reinfection, that's MMWR. And basically the bottom line is that if you actually have had COVID, native COVID, there is a 2 to 3-fold decrease, a 2.3-fold decrease odds of reinfection with vaccination. So if you had COVID, native COVID, like many of our firefighter EMS people have, and this sort of substantiates the recommendation that those individuals at the proper time should get the vaccine as well. Okay, so in summary, I think we have good evidence for booster dose. Number 2, that if you actually have had COVID, that you would benefit from a second shot here as well. And finally, that the older patients respond quite well to the booster dose.
Yeah.
Oh, can I ask John a question real quick?
Yeah.
Can the man on vacation please ask a question?
I can't get enough. John, great presentation. My question for you is, given the fact that the folks in the UK spread out their dosing schedule to 3 months, or I guess was 12 weeks, yeah. And then, you know, they had a better outcome with Delta. If you had to kind of rewrite the script again, you know, given the data you're just showing us, do you think it was right to do the 21 days for Pfizer and then the booster later, or do you think that interval should be changed given the data that you see today?
Peter, that's a great question. I have absolutely no data here to say what I think. I actually think that 21 days is proper because you need to look at both the antibody dose as well as the T-cell immune responses. So you have to really be careful about the booster doses, and obviously Pfizer and Moderna basically timed using animal models with the 3 to 4 weeks of booster dose as well. I do think that it depends on what you look at. The T-cell responses are really important for severe disease. And it's interesting from a pathogenesis, SARS-CoV-2 is really an interesting virus. And basically, if you look at the way it infects, it's unlike that many of the other COVID-2 virus.
Lost you there for a second, John.
Kids get SARS-CoV-2 multiple times.
Yeah.
Yeah.
May I make a comment? Or actually more of a question to you, John. There's several papers, recent ones, about the P681R mutation, P681R mutation, which is on the spike of the Delta variant and is considered a hallmark of the Delta variant. And the papers are showing that mutation, the P681R, allows virus in one cell to alter the cell so that it forms syncytia, so that there's
Yes.
fusion, right? And that therefore virus is not going to get doesn't need to go extracellular and then bind to a new receptor to get in. So antibodies from these vaccines that we've made to the receptor binding domain would reasonably be less effective when a virus is able to sneak from one cell to the other and avoid the antibodies. Would you agree?
I agree with that completely. So if you actually look at the Nature actually has a really good, easy to understand report of how the virus actually infects the patient, infects the cell. And the SARS-CoV-2 basically reprograms the mitochondria as well as the endoplasmic reticulum, and basically forms syncytia and different bodies, and basically inactivates the interferon in many different ways here as well. So that mutation, I think, Eileen, remind me, it's on the S1 portion, isn't it, as well?
Yeah, here, let me just, here.
Yeah, but I think the answer is yes. So this, what Eileen is really saying is that the spike protein is only part of the defenses. Once you have syncytia formation, you need both antibodies, which prevents it, and the T cells to target the syncytia. Absolutely.
And less apt to get those if you're older, right?
Yes, that's correct. The older people actually, it's sort of interesting. I think it came from a very well-run labs. There's 1 or 2 papers suggesting that the older people recognize the virus, but they've been programmed against the other coronavirus. So they're busy making the wrong antibodies and the wrong cells, and their immune system is not as awake. And by the time they figure that out, it's too late as well. So I think this coronavirus is really a tricky animal, or a virus.
Yeah. Hey, so the bottom line I have is this, right, John? Okay.
Yes.
Where's the other one? I lost it here. I got 3 of them here. So. Okay. All right. I
got a quick question, John. That Kentucky study, by the way, I've been looking forever for what is the vaccine breakthrough rate for natural immunity. So finally we have this one. But other than the odds ratio, I didn't see them actually list percentage of people that got infected in either groups. Did you see that anywhere?
No, but I think if you read the React 1 report, which is their term 13, it has it in the text, Ken. So I'll try to look at it. They give you the number of actually the way they had their study. So you can extrapolate that number.
Great, thanks.
Hey, let me quickly run over to Libby out in Hawaii, the health director there. So what's going on in the state of Hawaii, just real quickly? Anything to report on for us?
Hi, Paul. We're having a state of confusion in the state of Hawaii.
Okay, cool. Okay, well, thank you. See you later. Who's next? No, I'm just kidding.
Yeah, we're seeing high numbers, and really for us, it's the very first time that we're seeing such high numbers. We've managed to escape the really gigantic crush of COVID until about now. We had topped off at like 300 cases a day, and that was last year in August. And then we went into lockdown, and when we came out of it, we haven't really had a huge spike. We're topping 600 cases a day now. Hospitals are getting real nervous and are getting full. We're bringing out some surge staffing for that. We have a vaccine mandate that just went statewide and countywide, so that should help. And then we're re-implementing restrictions in gathering size in restaurants and whatnot. And we finally yesterday got our tourism guys to say that, the tourism situation is a 220 volt circuit, and the infrastructure here is 110, and the tourists are just frying us. We're getting 33,000 arrivals a day, and it's just overwhelming us. And it's breeding terrible animosity because, the tourists are 7 deep walking down the sidewalk in Waikiki with no masks. And meanwhile, we're telling the residents they need to go back to restrictions on gathering sizes and whatnot.
Okay, yeah, but all I can say is, I mean, you got a tough job there, friend. That's all I can say.
Yeah, it's just very limited resources, that's all.
Thanks for filling us in. That's interesting, though. Hey, Rob Dunn, we hadn't heard from you for a while because you're such a busy guy in Detroit. Anything else to add to the conversation today?
We're basically
kind of like some of the others, we're playing to roulette here with a lot of confusion, not a lot of guidance from some of our officials. The entire southern half of the state is now in substantial transmission. We've had day-to-day increases in ED visits. We're nowhere near as bad as some of my colleagues on this call, fortunately or unfortunately, but we still have big parts of the state, including a lot of the state of Detroit, that really lags behind in vaccination. So that's been our ongoing focus and concern. We've had a few breakthrough cases in some of our EMS agencies, but fortunately not very many.
Okay, got it. Hey, Ben, I saw you just jumped on from Baltimore. What do you have to say there?
Hey, everybody. Well, that's sobering listening to the Florida and other stories. You know, we have been somewhat lucky because in Baltimore and in Maryland, our case rates and positivity rates have been somewhat less than the rest of the country. Our mayor also has a mask mandate, but certainly we're starting to see I know Peter had mentioned this too, the effects of an already overburdened system. So while COVID has not been the primary driver of EDs being busy, when you put that on top of a system that is already completely over-resourced or under-resourced, I should say, it's very difficult. We're starting to deal with a lot of the wait times and things such as that. But yeah, I think it's certainly a lot of sobering news coming from the rest of the country. So we definitely appreciate sharing all of the mitigation strategies.
Okay, well, hey, a quick question. Sandy Schneider put in this thing about some of the doctors are actually going in and getting booster shots right now on their own. Like, I guess you could just go around and say I need a shot, etc., and just say I didn't get my second shot, or I'm here for my second shot, or whatever. I don't know what they're doing. What are the either legal aspects that are regulatory and maybe ethical issues regarding? Okay, so anybody know about that? Is it can a doctor order a shot for themselves or for their friend or whatever? Does anybody have any knowledge about that?
Yeah. Well, I think. Yeah, sorry. Go ahead, Peter.
No, go ahead.
I think the EUAs were very specific. If you actually look at our vaccine partners, you are FRON down here as well. Once it comes off EUA and formulation, you can go off labels, like all of us know here as well. So I think it depends upon how much vulnerability you want to take with your partners on the vaccine side.
Okay, got it. So you're saying that with the EUA, that's not really permissible, right? And
yes.
Yeah, that's right. And then, but maybe if it gets approved, then you could do where you want, so to speak. Right. Okay, Peter, what were you going to say?
Yeah.
Something different?
Yeah, I can tell you, I've gotten 1,000 phone calls with this exact question, and of course, I'm telling people that it's not allowed yet. But what I have heard people are doing, because you know, in the state, especially in our state, your data doesn't get updated until the next day into the system, so people are not verifying your data. I got a call from a 94-year-old guy who said he just went into Costco and said, I want a shot. And they said, oh, why didn't you get vaccinated yet? He said, no, I got COVID 3 months ago and they told me to wait for my shot, which is not true. And they happily gave him a shot, and he's happy as a clam. So I think with all the news of what's happening in Israel and people who have antibody tests who are sending me their antibody tests with no antibodies, at least on the little $5 cheapo tests. There are people who are rightfully concerned. And you heard Fauci this weekend say that it's coming, that the immunocompromised will be next in line. But part of me is asking how much of this is kind of more politically driven, that they're holding back on this next booster dose versus how many people are going to be affected negatively because they're older and have no antibodies. So that's just my little rant. Thank you.
Yeah.
Hey, Paul, I would worry about people getting the third shot. What's the side effect profile going to be from a third vaccine? Amal may be talking to us about significantly higher rates of cardiac complications and every other complication if we go to a third shot within a year period. I'd be very concerned.
So we have no data really, but a priori, we do know that the immune system is definitely going to be having a better, is going to be improved. The question about side effects, I actually, myself, I'm not really worried about that being a big issue. I expect that to be a very unlikely to be significant, but we don't know. We don't have the data.
I actually agree with Eileen for the mRNA vaccines. I think you need to be careful with the adenovirus vaccines because of vector, not for the spike protein.
You betcha.
I agree. I agree.
Does anybody have any intel on whether they're working on boosters for Delta specifically, or?
Yes,
yeah.
Eileen probably knows better than I do, but yes.
100%. He's right. They are. Both Pfizer and Moderna are well into that. You know, there's, you know, just to be clear, right now, 294 different COVID vaccines being at different levels of production worldwide. Yeah.
Okay. Hey, Eileen, just out of curiosity, I know that you got bumped by Cuomo for whatever reason. I don't know why, you know, not always one way. But listen, but what were you going to talk about, just out of curiosity? Do you know what it was going to be about?
Masks in Florida. That was one of their big concerns. Because of course, you know, two physicians basically poo-pooed the use of masks, you know, Wall Street Journal article. I'll be right up front with you. I stopped reading or subscribing to the Wall Street Journal the day Rupert Murdoch purchased it, because to me, Rupert Murdoch equals liar. You know, those are synonyms.
Yeah.
So yeah, but that's my own personal bias. I went through the document with great interest, and you know, there are some valid minimal arguments that are in there, like it can fog your glasses if you don't wear it right, and if you don't know what you're doing, and which mask are you using. I mean, all of that's very relevant, and it is true that we haven't done massive studies on children specifically, but you don't need to do massive studies on children specifically to understand the dynamics and the reality of the value of the masks. Anyway, I was going to go into all those details.
Yeah.
Yeah.
And you always do it so well. So thank you so much. So I'll be watching. I'll still try to. I'll use my Xfinity thing to download and keep watching every day. Can't avoid. Yeah, like I said before, I think I should take out an insurance policy. If I have to see you again, I can file a claim for damages, and I'll be very rich pretty soon, right? You've been great, doing a great job for us. Really appreciate it. So I think that's we've kind of won over the hour longer than usual. You know, it's kind of cool because I could sit here and talk to you guys all day. It's just fascinating. Anybody else want to contribute anyway and get on, or please always let me know in the future if you want to get on and talk about something, because I am always anxious to have you on and so on. So, any of you. So please let me know, of course. All right. So everything else, anybody else have anything else to add into it before we move on? So. Hi, Lakshmi. Good to see you. Who's that with you?
There you go. And a chew on my hand. I just wanted to say it's reassuring to hear that it's bad everywhere. We are really struggling. Our EMS activation rates and EMS call holding is really high. The hospitals are beyond full. We have our supervisors trying to turn the ambulances around as soon as I get there. And somebody had asked about the NEDOC score and if there were people using it. This whole diversion thing has me totally, I mean, I'm tired of the diversion thing, but this is our, like people, they use the NEDOC score and this is what happens. Everybody is at severe, everybody is on diversion. I mean, we have nobody that isn't. So
right.
It just, I mean, I don't think it adds any value at this point other than saying, yeah, one hospital is on diversion, everybody is. I mean, we were at less than 5% positivity rate. We've jumped up to 10 in Fulton County, so more than double. And all the schools opened last week, mandatory masking, but they did open. So we're expecting that surge. And we're pushing vaccine efforts. The biggest difference is we have the numbers and life seems to go on. It's not like the first surge where everybody stopped. Okay. So it's just getting worse. And many of the hospitals in the area are actually mandating vaccines, which they have given a deadline and they're planning on mandating them. So that's something that we are looking toward and telling people. With Emory, they're saying if you are not vaccinated, you got to get tested every week, or as a deterrent to say you better be vaccinated. So there's the push for vaccines.
Yeah. So then there's also the interesting thing, we'll come back, maybe we'll talk about this again next week, about the issue of the semantics of mandate versus required, which is an interesting thing. It's just like, sometimes it's like gun control versus gun safety, a little, there's some of the political buzzwords that are there.
Sure. Yeah, I should use the word required. I shouldn't use the word
Yeah.
mandate, but
So one thing I do want to say, though, is I'm trying to scan all this stuff here real quick. But one thing I do want to say, Peter made the point that the doctor advised blah, 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 et cetera. And keep in mind that a lot of the doctors don't have the advantages of what we have here, where we have some experts, as well as people who are really up to date on a lot of this stuff. And we get really good, reasonably good and up-to-date information here. Whereas I've seen some judgment calls on people, like the obstetrician not telling the woman not to get her vaccine shot while she's pregnant, kind of thing. And so we were very fortunate to have that. To just remember, out there, the medical community may not have all the most up-to-date information, and they're trying their best. I'm not being critical, but we're very fortunate to have this advantage here. And lastly, I want to thank, and I should do it more often, but thank both David and Julian for and all of District 7 and their board and their chief for allowing us to still have this incredible forum. It is amazing, and it's just been, I think, life-saving, in fact, in many respects, let alone that we're all the things that Lexby just said. You're feeling pretty beat up, but you got friends out here, and that's what's kind of good, that we're all screwed together. But it is good to have this group to be able to to know that you're not alone out there, and we hope it can be a resource for you. So okay.
Hey, Paul, you're bringing us all together. Thank you very much. You keep bringing a bigger group together. We're very grateful.
Okay, good. Well, anyways, I know why some of my European colleagues weren't on today. I'll have to explain later. But thank you all very much. I think it's time we should all depart at this point in time. Unless anybody else has anything burning, I'm glad to hear anything else from anyone else out there that's joined us. Okay. If not, then welcome back, my friends, to the show that never ends. Next Tuesday, same time, same station, as they say. And as you go out, I'll leave you with, let's see if I can find the thing I can leave you with here. I'll leave you again with that the great detection system that I had this past week. Okay, here we go. Thanks to Erica Carney and her team. See you later, everybody. If I never try, I will say all right, I'll see. I'm off to Omaha in a couple of days for the same thing. Take care, everybody. Bye-bye.